এটা কিছু বোঝা যাচ্ছে? Excessive proliferation of cells causes cell mass that is known as tumor. তাই তো? এই টিউমার দু রকমের। টিউমার্স আর অফ টু টাইপস। ওয়ান ইজ benign that has very slow growth rate defined to a localized area with well defined margin, and the another one is malignant tumor that has rapid growth rate that can spread locally spread that can spread to local area or distance area. This malignant tumor is known as cancer. বোঝা গেল? Cancer is the second most common of death in developed countries. Second to developed country te second to cardiovascular disease. Or in our country, which cancer is more common? জানিস কোনো আইডিয়া আছে? হ্যাঁ, কি সেটা অনলি ফর ফিমেল। ফিমেলদের হচ্ছে যে সার্ভাইকাল, আর আমাদের মেলের হচ্ছে লাংস। অ্যাজ এ হোল হচ্ছে যে গ্যাস্ট ওরাল অর জিআই আপার জিআই ট্র্যাক্ট ক্যান্সার ইজ দ্য ফার্স্ট কমন কজ অফ ডেথ ইন আওয়ার ইন্ডিয়া। বোঝা গেল? Next, cancer is a disease of mainly predominantly cancer occurs in old age. Why it occurs in old age? Because normally one mutation occurs 10 to the power 6 cells division. As we grows or becomes adult, 10 to the power a lots of mutation occurs in our body. With the passage of time, mutation accumulates in our body that leads to cancer. That's why cancer mainly of disease of adult age, preferably or predominantly over the 60 years of age. But এরকম কোনো ধরাবাঁধা নিয়ম নেই যে ইয়াং এজে হবে না, ঠিক আছে? এটা হচ্ছে একটা। Next, I am coming to the characteristics of cancer cells. Cancer cells are having the such characteristics. First, the loss of shape and size. Every normal cells have its own shape and size, like muscle cells that are spindle shaped, liver cells that is hexagonal shaped. After becoming the cancerous, they lost their own structure by normal shape and size, and then they comes to round or spherical. বোঝা গেল? নেক্সট ইজ দ্য কন্টাক্ট ইনহিবিশন। নর্মাল সেলস হ্যাভ কন্টাক্ট ইনহিবিশন, দ্যাট মিনস দে সিজ টু proliferation when they comes in contact. in cell culture media or cell culture dish, but cancer cell loses this property. Due to the normal, that's why the normal cells produce monolayer cells in culture dish, whereas the cancer cell produce multilayer. মানে ultimately normal cell এরকম হবে। ঠিক আছে, ক্যান্সারের ক্ষেত্রে মাল্টিলেয়ার হবে। নেক্সট হচ্ছে লস অফ অ্যাঙ্করেজ সাপোর্ট। নর্মাল সেলস adhere to the surface of the culture dish during in vitro. In vitro মানে কি? What is the meaning of in vitro or in vivo? What is the difference between in vivo and in vitro? হ্যাঁ, বুঝতে পারছি না, আর কি বসেই বল। ভিভো মানে ইন, হ্যাঁ, exact, correct. But the cancer cell lost this property. They need no anchorage support of culture dish for their growth. Next হচ্ছে যে reduced requirement of nutrition. Normal cells requires nutrition and growth factor for their growth, but cancer cells require but less amount of nutrients and growth factors are required. Most often they also produced growth factor of themselves. ঠিক আছে, নেক্সট হচ্ছে ইমমর্টালিটি। হোয়াট ইজ মিনিং অফ ইমমর্টালিটি? কি বুঝিস ইমমর্টাল অমর? ঠিক, এটা ছোটকালে ইয়ে লিখতে হতো না, ম্যান ইজ মর্টাল, ম্যান ইজ, হ্যাঁ, ম্যান ইজ মর্টালটাকে কীভাবে নেগেটিভ ইয়েতে করা যায় জানিস? ম্যান ইজ মর্টাল হলে ম্যান ইজ নট ইমমর্টাল। ঠিক আছে, মানুষ মরণশীল, মানুষ অমরণশীল নয়। ঠিক আছে, নেক্সট। ইটিওলজি অফ ক্যান্সার। ঠিক আছে, এক্সাক্ট ইটিওলজি মানে কি, কী কী কারণে ক্যান্সার হতে পারে, মানে পজিটিভ ফ্যাক্টর, কারণ কী কী কারণ। এক্সাক্ট ইটিওলজি অফ ক্যান্সার ইজ নট known. Basically it is a multifactorial disease. There is a combination of or single, it may be due to genetic, environmental, physical, যেটা তোরা কার্সিনোজেনেসিস পড়ানো হয়েছে, ও কার্সিনোজেনেসিস, ও কার্সিনোজেন, অনকোজিন পড়ানো হয়েছে, অ্যাপোপ্টোসিস পড়ানো হয়েছে। আচ্ছা, হরমোনাল, ফিজিক্যাল, কেমিক্যাল ফ্যাক্টরস and many agents can cause cancers. The agents which can cause cancer, that is known as carcinogen. There are various carcinogens which I am giving a little physical agent বলতো কি কি? Chemical agents that are divided into agricultural, that is insecticide, pesticides, smoking. Benzpyrene is important carcinogen that is present in smoking. Next হচ্ছে ইন্ডাস্ট্রিয়াল এরিয়া, অ্যানিলিন ডাই, অ্যাসবেস্টস কজেস ক্যান্সার। নেক্সট হচ্ছে ফুড অ্যাডাল্টারেন্স। এই সমস্ত জিনিসগুলো ইয়েতে পড়ানো হয়েছিল অ্যাকচুয়ালি, তো জেনোবায়োটিক্সের সময়, বা তোর হচ্ছে ডিন্যাচুরিং এজেন্টের সময়ও পড়ানো হয়েছিল মোস্ট প্রবলি, কিছু কিছু এজেন্ট UV দেখ আচ্ছা নেক্সট হচ্ছে বায়োলজিক্যাল, দ্যাট ইজ দ্য ইম্পর্টেন্ট থিং। Also known as viral oncogenes. It is an important key factor for cancer development. There is lots of viruses that are closely associated with the cancers. ঠিক আছে? First identified virus causing cancer was Rous sarcoma virus in 1911. It causes cancer in chicken. Thereafter, lots of DNA or RNA viruses have been detected or identified that are strongly associated with the cancers. ঠিক আছে? I am giving some important virus and their cancer, their related cancers. C virus, that is associated with hepatocellular cancer. Next one, HPV, that is associated with cervical cancer. Next one, EV virus, herpes simplex virus, that is associated with Kaposi sarcoma. Next EV virus, Epstein-Barr virus, that is B-cell lymphoma, associated with B-cell lymphoma. Next, I am coming to the genes are associated with, the 4 types of genes are associated with the cancer causation. These genes are known as oncogenes. ঠিক আছে? There are 4 types of genes. Four types of genes are associated with genes that are associated with cancer known as oncogenes. Four types of genes are there. That is group 1. Group 1 cells are inducing cell proliferation. Group 2 oncogenes inhibiting cell proliferation. That is also known as tumor suppressor gene. Next, group 3, that is oncogenes regulating cell death, are 4 genes involved in the DNA repair. DNA is the main culprit for developing cancer. Okay? Next, the mechanism by which they act. First one হচ্ছে group 1. Group 1, they cause various mode of action of oncogenes that by that they causes cancer. First one, group 1. Group 1 genes produces cancers in several ways, like or substance that is resembles to growth factor. Simian sarcoma virus or cyst oncogenes produces this type of platelet derived growth factor that acts on platelet derived growth factor receptor present on the mesenchymal cells. That is, mesenchymal cells is associated with wound healing. These oncogenes also causes, or this product produced by the cyst oncogene causes autocrine stimulation of the cells and leads to or transform to malignancy. This type, for example, sarcoma or tumor of muscle cell and glioblastoma, that is tumor cells. Next হচ্ছে oncogenes products as growth factor receptor. আগেরটা গেল growth factor, এটা হচ্ছে যে growth factor receptors. Oncogene products are acts like growth factor receptor. Products that is ERB gene produces EGF, endothelial growth factor receptor. This receptor acts as active receptor and causes mitogenesis. What is mitogenesis? Cell division. Next হচ্ছে oncogene products acts as tyrosine kinase enzyme. Tyrosine kinase enzyme পড়েছিস তোরা কোথাও? অ্যাপ্রোপ্টোসিস পড়ানো হয়েছে? নাহলে বোঝা খুব মুশকিল। আচ্ছা, that is VSR gene, that is sarcoma causing viruses, acts like a tyrosine kinase activity, has a tyrosine kinase activity which influence a large number of processes present in the cell and causing malignant transformation. Next, coming to oncogene product acting as abnormal G protein. ঠিক আছে? Rouse sarcoma virus gene is a point mutated protein which acts like a G protein. Being mutated, this G protein has lost GTPase activity and it remains active. That leads to malignant transformation. ঠিক আছে? Next হচ্ছে oncogene products acts like transcription factor. NMYC gene, that is myelocytosis Gene products acts like a transcription factor which augments gene expression and thereby causes cancers. Examples is the breast, stomach. আচ্ছা নেক্সট হচ্ছে যে গ্রুপ টু জিনস that inhibit proliferation of cells is an important for exam as tumors are surgery. Tumor suppressor gene. ঠিক আছে, they are also called anti-carcinogens. They prevent tumor formation. It is now believed that many tumors have abnormalities of tumor suppressor gene. It is an important topic. ঠিক আছে, there are 4 types of tumor suppressor gene in our body. First one is P53. নাম শুনেছিস? হ্যাঁ শুনিস নি? পড়তে হবে কিন্তু পরীক্ষা আসবে। আচ্ছা নেক্সট হচ্ছে রেটিনোব্লাস্টোমা জিন, আরবি জিন। থার্ড ওয়ান ইজ নিউরোফাইব্রোমাটোসিস জিন 1 and fourth one is adenopolyposis of colon gene 1. Retinoblastoma gene or P450 gene, that is tumor suppressor gene, also called guardian of genome. এটা তো এমসিকিউ আসছে এইচএস লেভেলে, নেটের এন্ট্রি নেই, হ্যাঁ আমরা পর্যন্ত ইয়ে করছি। আচ্ছা it is located P450 gene, it is located on the chromosome 7. ঠিক আছে, mutation of P53 gene is most widely associated with the tumor. It is estimated that 50% tumor is associated with the mutation of P53 gene. ঠিক আছে, এটা কিন্তু P53 gene itself পড়তে হবে, you may get a short note on it. ঠিক আছে, P53 gene protein its molecular weight is 53 kilodalton. ঠিক আছে, which this protein stabilizes cell cycle. পড়ানো হয়েছে সেল সাইকেল 11-12 সেই সালে ক্লিয়ার আছে না? কটা স্টেজে হয় সেল সাইকেল? কটা? আচ্ছা 4টে, তাই তো? ঠিক আছে, আচ্ছা ঠিক আছে। P53 gene stabilize the cell at G1 and G2 চেক পয়েন্ট, দুটো চেক পয়েন্ট থাকে সেল সাইকেলে, তাই তো? জানিস পড়া হয়নি তো? আচ্ছা, when there is an injury or DNA damage in the cell, the amount of P53 gene rises. This P53 gene halts the cell cycle and gives time to the cells to repair the injury or DNA repair. If the cell can sufficiently repair the DNA, then the cell cycle goes ahead. Or if the repair is not sufficient, then P53 gene channelize the cell to apoptosis. ঠিক আছে, অ্যাপোপ্টোসিসের একটা বড় উদাহরণ কি বলতো? প্রেগনেন্সি ডেলিভারির পরে হচ্ছে যে যেটা হয় আর কি, এটারও এমসিকিউ ছিল। এইচএস লেভেলে নিটে, ঠিক না? হ্যাঁ, হাইপারট্রফি আর সেল পলিফারেশন দুটোই হয় ইয়েতে, যখন প্রেগনেন্সি হয়, ইউটেরাস বড় হয়ে যায়, ঠিক আছে? তারপরে কি হয়, আফটার ডেলিভারি ইউটেরাস বিকামস শ্রিঙ্কেজ, ইট ইজ আর প্রমিনেন্ট অ্যাপোপ্টোসিস হাইপার, ঠিক আছে? নেক্সট হচ্ছে রেটিনোব্লাস্টোমা জিন। Retinoblastoma gene was first identified in the neuroblastoma that occurs in retina, known as retinoblastoma. ঠিক আছে? Normally it presents in our body. It is located on the chromosome 13. Its product, or it produces a nuclear phosphoprotein that controls the cell cycle at G1S phase. ঠিক আছে? It has been seen that many viruses causes cancer by inactivating these RB genes. ঠিক আছে? Not I am going in detail. Next I am coming to cancer metastasis. Why cancer metastasis? What is the meaning? ঠিক আছে, সব আস্তে আস্তে শিখে যাবি, পরে সেকেন্ড ইয়ার কি বলে, সেকেন্ড প্রব আছে, থার্ড প্রব আছে। ক্যান্সার সেল মেটাস্টেসিস রেফার্স টু দ্য অ্যাবিলিটি অফ ক্যান্সার টু স্প্রেড, ঠিক আছে? ইট ক্যান আইদার স্প্রেড টু দ্য লোকাল এরিয়া বাই ব্রেকিং দ্য বেসমেন্ট মেমব্রেন অফ দ্য সেলস, or it can may spread to the distance area by vascular spread. দুটো মোড, একটা লোকাল মোড আর একটা হচ্ছে যে ডিস্টেন্স মোড বা ভাস্কুলার মোড, যেটা আমরা বলি মেটাস্টেসিস ক্যান্সার হয়েছে, ঠিক আছে? How they cause? First one is the cancer cells expresses laminin receptors that produces plasminogen activator, and that binds with the these laminin receptors. laminin কোথায় থাকে? আমি যখন ইসিএম পড়ানো হয়েছিল, হ্যাঁ, laminin is a component of cell base membrane, ঠিক আছে? This laminin receptor binds with the laminin protein present in the basement membrane, ঠিক আছে? And thereby produces plasminogen activator and procollagen 5, procollagen 4. This plasminogen activator converts the plasmin to plasminogen to plasmin. Plasmin is a protease enzyme that breaks the protein of the ECM. ECM এর যে সমস্ত প্রোটিন থাকে, কি কি প্রোটিন থাকে মনে আছে? কোলাজেন, ফাইব্রিলিন, ল্যামিনিন সমস্ত থাকে, মনে নেই? ঠিক আছে, আচ্ছা। That breaks the proteins of ECM and activates the procollagen to collagen fiber. This plasmin and procollagen 4 combinedly degrade the basement membrane and helps the carcinogen cells to spread. Next হচ্ছে carcinogen cells also produces VEGF অর্থাৎ ভাস্কুলার এন্ডোথেলিয়াল গ্রোথ ফ্যাক্টর and FGF, that is fibroblast growth factor, that helps in the formation of new vessels, that also important for the cancer spreading. Third one হচ্ছে যে cancer cells decreases cell to cell adhesion, তার মানে লুজ হয়ে যাবে, স্প্রেড করাটা ইজি হবে। ক্যান্সার সেলস, fourth one, cancer cells alters the permeability and transport mechanism of the cells. This also helps in spreading. Fifth one, cancer cells causes loss of old antigen and appearance of new antigen. That also helps for spreading. This is all about cancer in base level. ঠিক আছে, নেক্সট সেকেন্ড প্রপ থার্ড প্রপে গিয়ে সারা জীবন সঙ্গে থাকবে ক্যান্সার। ঠিক আছে, তো ক্যান্সার পিছু ছাড়বে না আপ টু ডেথ অফ এ ডক্টর। ঠিক আছে, ওকে, থ্যাংক ইউ অল অফ ইউ।
Today's discussion is on Vegas. Actually, it's a big part. Naturally, I have to rush through, and I will just tell you the headlines and a bit of description. The rest, I won't go to detail because it will take then 2 hours. So, get it, just idea, and today you go back and finish Vegas and let it incubate in your incubator. Now, the cranial nerves, sensory nerves are 1, 2, and 8. Motor nerves are 3, 4, 6, 12. Mixed nerves are 5, 7, 9, 10, 11. You just, the cranial nerves, you just distribute and classify into sensory nerves, motor nerves, and mixed nerves. Once you do this, the cranial nerve nuclei, every book has these pictures. Now, you see the olfactory nerves, the optic nerve, the oculomotor nerve, the ophthalmic nerve, maxillary nerve, mandibular nerve, and trigeminal nerve, vestibular, cochlear nerve, axillary nerve. And over here, you see the optic nerve, trochlear nerve, the abducens nerve, facial nerve, glossopharyngeal nerve, and glossal nerve, and the vagus nerve at this level. Now, this is the distribution. This is a beautiful illustration showing the definitive organs of the cranial nerves supplied by the cranial nerves. Now, the vagus nerve. The vagus is the 10th cranial nerve. Due to its vague or extensive course, it is termed as the vagus nerve. It is the longest and most widely distributed cranial nerve. So, the characteristic of the vagus nerve, it has a vague, extensive course. It is termed as the vagus nerve. It is the longest and most widely distributed cranial nerve. Now, the functional components, efferent fibers, special visceral efferent, SVE. This leads to they supply the palate, pharynx, larynx. They arise from the nucleus ambiguous. General visceral efferent, GVE fibers, they are preganglionic parasympathetic fibers for thoracic and abdominal viscera. They arise from the dorsal motor nucleus of the vagus. Afferent fibers. Now, efferent and afferent fibers. Now, the efferent fibers is having the special visceral SVE fibers. That is it originates from the nucleus ambiguous. General visceral GVE fibers, they preganglionic parasympathetic fibers for thoracic and abdominal viscera. They arise from the dorsal motor nucleus of the vagus. Afferent fibers, general visceral afferent fibers, they carry sensation from the larynx, esophagus, carotid body, and from thoracic viscera to the lower part of the nucleus tractus solitarius, and few fibers to the dorsal nucleus of vagus. Special visceral afferent SVA fibers, they carry taste sensation from the posterior most part of the tongue, epiglottis to the upper part of the nucleus tractus solitarius. General somatic afferent fibers, they carry general sensation from the skin of the external ear to the spinal nucleus of the trigeminal nerve. Now, you have to practice this figure. It is in the competency based that you have to, this can be coming a question. So, you see this, you get it in your books. This illustration is from Eurasia. Anyway, the practice figure, this is a practice figure, functional components and nuclei of the vagus nerve, right transverse section passing through the medulla oblongata, superior and inferior ganglia of vagus nerve are shown in the dotted line. Now, see, it is in the transverse section. This transverse section passing through the medulla oblongata. At the level of the medulla oblongata, you see the nucleus. This is the nucleus ambiguous. This is dorsal nucleus of vagus. Then nucleus tractus solitarius. Spinal nucleus of the trigeminal nerve. Vagus nerve. These components is the vagus nerve. And this goes to the GSA, general sensory afferent, and CVA, the taste fibers, GVA, pharynx, larynx, trachea in red, and this is the green that gives you palate, pharynx, and this is the parasympathetic to the heart and respiratory tract. This, if you want to photograph, you photograph it. You take it in your mobile because you, it's very important because vagus nerve is associated with laryngeal nerve, naturally recurrent laryngeal nerve. Now, vagus nerve flow chart, see the vagus nerve SV is special visceral efferent, general visceral efferent, general visceral afferent. Special visceral afferent, GSA, general somatic afferent. Now the vagus nerve branches, the functional components and nuclei are, and this is the branches to the head and neck and the thorax and the abdomen. Now functional components of the nuclei, SVE, nucleus ambiguous of palate, pharynx, motor nucleus of vagus, parasympathetic fibers of thorax, and GVA nucleus tractus solitarius. Now you have to mug it up. तो मगे रटना है. This vagus nerve is very important, and also now the branches in the head and neck, meningeal branches, auricular branches, pharyngeal branches, carotid branches, superior laryngeal branch, external and internal laryngeal nerve, recurrent laryngeal nerves, superior and inferior carotid branches. If you see the anatomy of the neck and the position of the your vagus nerve, so these, whatever the organs are there, pharynx, and the carotid artery, it contributes there, it supplies there, and it goes down into the thorax. It also gives the branches in thorax. Now the left recurrent laryngeal nerve, cardiac, tracheal, esophageal branches to inferior constrictor, to all intrinsic muscles of larynx, cricothyroid, sensory branches of larynx below vocal cord, and pulmonary branches, carotid branches, esophageal branches. To me, you just think, you just see the specimen, see the your atlas dissection manual, and you just compare. And one thing is that every structure has some duty to perform. And especially the vagus nerve, what is it is having different components, and at different levels of the, from head, neck to the thorax to the abdomen, it goes and supplies. Naturally, what are the organs and what are the structures that is supplied by the vagus nerve is seen here. Now, the abdomen, from anterior vagal trunk, hepatic branch, upper gastric branch, greater anterior gastric nerve. From posterior vagal trunk, gastric branches, celiac branches, nerve of the gastric. Now, you just see the vagus anterior, posterior, and from the anterior trunk, the viscera and in the abdomen, and posterior trunk, the gastric branches, celiac branches, and the. Now, the functional components, nuclei and function of the vagus nerve. Functional components, nuclei, function. Now, special visceral efferent, nucleus ambiguous, palate, pharynx, and larynx. General visceral efferent, motor nucleus of vagus, parasympathetic fibers of thoracic and abdominal viscera. General visceral afferent, nucleus solitarius, dorsal nucleus of vagus. General sensation from pharynx, larynx, esophagus, from thoracic viscera and carotid body. Special visceral afferent, nucleus tractus solitarius, the taste sensation from posterior most part of the tongue and the epiglottis. General somatic afferent, nucleus of the spinal tract of the trigeminal nerve. General sensation from the skin and external ear. Surface attachment of the last four cranial nerves. The anterior view of the brainstem. This is the pons. This is the middle cerebellar peduncle. Actually, the cerebellum is removed. The cerebellum is removed, and you can see the glossopharyngeal nerve, the vagus nerve here. Cranial nerve 10. This is the location. Now, you see the pons and the medulla oblongata. These are the vagus nerve, accessory nerves, the hypoglossal nerve. This is the pyramid, dissection of the pyramid, foramen magnum. Now, ganglia of the vagus nerve. The vagus nerve has two ganglia. Smaller superior ganglion or jugular ganglion. It lies within the jugular foramen. The superior ganglion contains cell bodies of the pseudo-unipolar sensory neurons, GSA, information from the pinna of the ear and external auditory meatus, and dura of the posterior cranial fossa. This smaller superior ganglion, larger inferior ganglion, nodus ganglion. It is lies just below the jugular foramen. It contains cell bodies of neurons that carry general visceral afferent sensory innervation from the mucosa of the soft palate, pharynx, from the posterior part of the tongue and the epiglottis. Note, the cranial root of the accessory nerve, 11th nerve, joins the vagus nerve just below the inferior ganglia. Origin of vagus nerve. The vagus nerve arises by about 10 rootlets. 10 rootlets, the vagus nerve arises and inferior cerebellar peduncle. The inferior cerebellar peduncle is positioned when I show you the cerebellum. It will be like this, middle cerebellar peduncle, superior cerebellar peduncle. Now, these rootlets emerge from the posterolateral sulcus of the medulla and unite to form the single nerve trunk. This. Now, course and relation. This is another question that can come. This is a practice figure. You have to practice this and see extra cranial course of last three cranial nerves, right lateral view. It's a very schematic diagram and you can easily remember. Now, the course and relation, the course of the vagus nerve is divided into following parts: intracranial course, in the neck, in the thorax, in the abdomen. Now, all these nerves, they come from the brain. Naturally, you put that point. Intracranial course, in the neck, it comes in the neck, in the thorax, in the thorax, in the abdomen, because what is its destination? What is the destination of a nerve from the brain, from the spinal cord? It has a definite course and direction and destination to reach. Now, so Vande Bharat starts from Bardhaman, intracranial course, and then comes to Khana Junction in the neck. Then it comes to Bhedia in the thorax and ultimately reaches Bolpur. Okay? You just মুখস্থ করছিস হ্যাঁ, মনে পড়ছে না, তাহলে এইভাবে ভাব দিলাম যে একটা নিউক্লিয়াস ব্রেনে আছে, সেখান থেকে নার্ভটা অরিজিনেট করছে, খুলি থেকে there are some openings that it emerges out of the intracranial course. Now, in the intracranial course, and the nerve rootlets of vagus nerve join to form a single nerve trunk that runs laterally. It passes through the intermediate components of jugular foramen in a common sheath of dura mater with the accessory nerve. তখন ভেগাস নার্ভ একটা বান্ধবী পেয়ে গেল আর কি, accessory nerve. হ্যাঁ, now it goes down in the neck. After coming out of the cranial cavity through the jugular foramen, the vagus nerve descends vertically within the carotid sheath in between the internal jugular vein and internal and common carotid artery. See, this is the 10th nerve. Now, this is the external carotid, this is the internal carotid. Okay, this is the internal jugular vein. এর মাঝে ভেগাস নার্ভটা নামছে। Internal carotid, internal jugular vein. Internal carotid and internal jugular vein. In middle, the vagus nerve descends. This is the posterior auricular artery from external branch of the external carotid artery. Now, this is the occipital artery, posterior belly of digastric, the digastric muscle. Yeah, posterior belly. This is the anterior belly. Now, behind the muscle, you can see the internal carotid artery here, and this component is the hypoglossal nerve. The hypoglossal nerve. It supplies the tongue, and this vagus is coming out in between the internal jugular vein and internal carotid artery. This is also practice figure in the thorax. This is also important. Practice figure, intracranial, extracranial course of last 3 cranial nerves. Right lateral view. Now, the right thereafter it passes behind the root of the lung. Further, it surround the posterior surface of the esophagus to form posterior vagal trunk. The left vagus is passed up to the root of the lung. It is separated from the left lung by the arch of the aorta. Further, it passes downwards, divides into branches, the surface of the esophagus to form the anterior vagal trunk. Now, this is important because I'll show you that vagus nerve in previous days mostly for gastric ulcer, peptic ulcer. They in our days, our teachers used to operate and they used to dissect out the vagus nerve and cut it. And to solve, it has an idea, but as things are changing, the cause of hyperacidity, acidity is our food related, and also H. pylori bacteria. H. pylori bacteria is a cause of peptic ulcer, hyperacidity and duodenal ulcers. So mostly if you have a Mahabhoj on your fest, আগে একটা পিপিআই খেয়ে নিচ্ছে, এনি বারাত ও বরযাত্রী আসছে, সেখানে অনুষ্ঠান ভবনের আগে দেখবে একটা কেমিস্ট শপ আছে, সেখানে গিয়ে একটা ওমেসডি হোক, প্যান্ডি হোক, এগুলো একটা ওটিসি ওভার দি কাউন্টার, ওসিটি ওভার দি কাউন্টার ড্রাগ হয়ে গেছে। তার জন্যে practically rebound acidity or reflux esophagitis or something like that due to misuse of this PPI occurs. But practically the concept has changed. Your hyperacidity is due to mostly is our food habit, and but main thing is H. pylori bacteria. H. pylori. You do a duodenoscope, upper GI endoscopy, and you have a test for H. pylori, root test. And also if you, the endoscopy, the gastroenterologist, if you feel by your clinical knowledge and also your taking the history of the patient, with what is there, if you have coffee ground, that means if a patient comes with pain in the upper abdomen, definitely vagus controls, but the ulcer component has many pathophysiology. Now once you feel, like in my prescription, I always, when I do an upper GI endoscopy, I request the gastroenterologist to perform one root test mandatory. Second is biopsy. একটা ছোট্ট টুকরো এন্ডোস্কোপ নিয়ে নিল, সেটা বায়োপসি করবে, বিকজ যখন এন্ডোস্কোপি করছে তুমি তো থাকছো না সেখানে, তো হোয়াট এভার ইমেজ ইজ সেন্ডিং ইউ, ইউ রিকোয়েস্ট ফর আ root test for H. pylori and your biopsy. Both the vagal trunks enter the abdomen through the esophageal opening of the diaphragm. Anterior vagal trunk divides into hepatic and gastric branches and runs along the lesser curvature of the stomach. Posterior vagal trunk passes posterior to the esophagus and gives gastric and celiac branches and nerve of Grassi. Branches and distribution. Branches in the head and neck from superior ganglion, meningeal branches, auricular branches. From inferior ganglion, pharyngeal branches, carotid branches, superior laryngeal branch, external and internal laryngeal nerves. Recurrent laryngeal nerve. This is a component which we will discuss in detail. Superior and inferior carotid branches. Amar বক্তব্যে, what I want to say is that the course of your vagus nerve, whatever the pathway it is going, it is supplying those viscera or muscles, whatever may be the components. তো এখানে কি কি আছে সেইভাবে তুমি ইমাজিন করে লিখতে থাকবে। Now in the thorax, left tracheal and esophageal constrictor to all intrinsic muscles of the larynx except cricothyroid. তার মানে তোমার ভেগাসের supply in intrinsic muscles of the larynx except cricothyroid. So sensory branches of mucous membrane of larynx below the vocal cords. Pulmonary branches, carotid branches, esophageal branches. In detail you get it in your textbook. From anterior vagal trunk. Now, from the anterior vagal trunk, the branches are hepatic branch of for liver, pylorus, duodenum, and pancreas. তাহলে বুঝতে পারলে যে লিভারের একটা কম্পোনেন্ট, একটা স্টমাকের পুরো এই pylorus, duodenum, and pancreas. Upper gastric branches for anterior surface of the body and fundus. Greater anterior gastric nerve, the main gastric branch, gives fibers to the body and antrum. It ends at incisura angularis in crow's feet pattern. It also gives pyloric branch to supply pylorus. You just draw a diagram of the stomach and কোথায় কোথায় সাপ্লাই করছে anterior vagus nerve, you just point an arrow indicating that it is the nerve. The yellow দিয়ে তুমি drawing করলে, then you just mark it. It becomes easy. Okay? Now, the gastric branches of the posterior surface of the stomach and except pylorus, your pylorus will be supplied. It major gastric branch is called greater posterior gastric nerve or posterior nerve of lesser curvature. Celiac branch reaches the celiac plexus via left gastric artery, nerve of Gracie for fundus of stomach. এটা এক নম্বরের MCQ থাকতে পারে. Now, course and distribution of the vagus nerve with the head and neck. View schematic representation, right lateral. Now you see the vagus nerve, superior ganglion, the meningeal branches, the inferior ganglion, the cranial root of axillary nerve here is coming. Now this nerve supplies the pharynx, palate, the pharynx and the palate, and to posterior most part of the tongue and the epiglottis, superior laryngeal nerve, internal laryngeal nerve. Now it comes to the carotid branch, it supplies, and this goes down. This is the recurrent laryngeal nerve. So in operation of the thyroid, for any thyroid nodule or thyroidectomy for any tumor of the thyroid, the surgeon has to take care not to injure the recurrent laryngeal nerve. Now you see in the dissection that the subclavian artery goes posterior to the subclavian artery and cardiac branches and into thoracic and abdominal viscera. This is a beautiful illustration. You can see the auricular branch, the meningeal branch, the vagus nerve proper, from the superior ganglion, inferior ganglion to the pharynx, palate, and tongue, and to the posterior most of the tongue and the epiglottis, superior laryngeal nerve, internal laryngeal nerve, and thyroid, carotid sinus. This is a practice figure of the vagus nerve in the head and neck schematic representation. Fibers of cranial root of the accessory nerve are shown in red color. Now, to thoracic and abdominal viscera. This is the vagus nerve, the meningeal branches, the cranial root of accessory, to pharynx, to palate, and the auricular branch, the carotid sheath. Now, you can see the internal laryngeal nerve and external laryngeal nerve. This is the recurrent laryngeal nerve in red, and this branch supplies to the pharynx, palate, to posterior medial part of the tongue and epiglottis, superior laryngeal nerve, internal laryngeal nerve, external laryngeal nerve, recurrent laryngeal nerve, cardiac branches, and the Now, what I want to say is that এই যে বারবার আমি বলতে চাইছি যে these are the organs in the head and neck and the thorax, these organs, and naturally তোমার যদি একটা জায়গায় হেড এন্ড নেকের ডিস্ট্রিবিউশন বলে তাহলে হেড এন্ড নেকে তুমি ফ্যারিংস লারিংস above the vocal cord এরকম করে বলে গেলে, হ্যাঁ, আর the rest it goes to the abdomen and in the thorax cardiac branches. Now this is one picture. These are again, it can be a short note, a distribution of anterior vagal trunk, B, distribution of posterior vagal trunk. So you can see the anterior vagal trunk, the left vagus nerve, the hepatic branch, pyloric branch, raw stomach, and the greater anterior gastric nerve. The gastric branches previous was the nerve of Lafayette. The gastric branches, the upper gastric branches. Now, posterior vagal trunk, you can see dotted. Now, the celiac branch, the celiac ganglia, and nerve of gastric, greater posterior gastric nerve, the body of the stomach, and the gastric branch. Now, branches of the vagus nerve in the head and neck. Branch function. Meningeal branch, sensory supply to dura mater of the posterior cranial fossa. Auricular branch supply the posterior half of the external auditory meatus. Spanning membrane and concha and the root of the auricle. Pharyngeal branches. So, vagus nerve with the head and neck branch. Meningeal, auricular, and recurrent laryngeal nerve left and thorax. Now, all the muscles of the pharynx except sternopharyngeal, which is supplied by the glossopharyngeal nerve. All the muscles of the pharynx is supplied by the vagus except sternopharyngeal muscle, which is supplied by the glossopharyngeal nerve. All the muscles of the soft palate except the tensor rami palatini, which is supplied by the mandibular nerve. Superior laryngeal branch, internal laryngeal nerve, sensation from mucous membrane of the pharynx, epiglottis, clavicular, laryngeal vestibule, mucosa of the up to the vocal folds. External laryngeal nerve supplies the thyroid and inferior constrictor of pharynx. Right recurrent laryngeal nerve supply all the intrinsic muscles of the larynx except icothyroid, which is supplied by the external laryngeal nerve. Mucous membrane of the larynx below the vocal folds. Some interesting facts: meningeal branches of the vagus enter the cranial cavity through jugular foramen. It supplies the dura mater of the posterior cranial fossa. Auricular branch, Alderman's or Arnold's nerve. It arises from the superior ganglion and passes behind the internal jugular vein. It enters the mastoid canalicus within the petrous part of the temporal bone. It emerges through the temporomastoid fissure and supplies the posterior half of the external auditory meatus, outer surface of the tympanic membrane, concha and root of the auricle. Now, this auricular branch, if you are answering the temporal bone, the base of the skull, you might be questioned. If you are answering for honors or some gold medal in that level. Okay. Now, all the muscles of the soft palate except tensor belly palatini, which is supplied by the mandibular nerve. Carotid branch, pharyngeal nerve of the inferior ganglion of vagus. It is nerve of fourth pharyngeal arch. Now, superior laryngeal nerve. It is the fourth pharyngeal arch. It is the nerve to the fourth pharyngeal arch. It passes downwards and forwards deep to the internal carotid artery to reach the middle constrictor. It divides into external and internal laryngeal nerve. Internal laryngeal nerve is a sensory nerve. It passes downwards and forwards towards the gap between the middle of the larynx. It carries sensation from the mucous membranes of the pharynx, epiglottis, vallicula, and laryngeal vestibule. Mucosa of the piriform fossa, area epiglottic fold, mucosa of the larynx, and the vocal fold. External laryngeal nerve is a motor nerve and smaller than the internal laryngeal nerve. Now, this actually the vagus is very, 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 very important. Everything is important. Now, this recurrent laryngeal nerve, write a short note on recurrent laryngeal nerve. It is the nerve of the sixth pharyngeal arch, beginning and course. Right recurrent laryngeal nerve arises from the right vagus at the root of the neck. It turns upwards around the right subclavian artery and then ascends upwards to the tracheoesophageal groove. Left recurrent laryngeal nerve arises from the left vagus in the superior mediastinum. It hooks around the arch of the aorta on the left side of the ligamentum arteriosus. Then it ascends upwards in the tracheoesophageal groove. Recurrent laryngeal nerve pass deep to the inferior constrictor muscle, enter the laryngeal cavity. Here they are called inferior laryngeal nerves. Now distribution. Now this recurrent laryngeal nerve is a very important. You might be asked in Viva, Voce, and also a theoretical question can come. So you have to give two illustrations. That is that I showed you earlier. That the vagus nerve supplying where it originate, and always ওটা যদি দেখে তুমি ভয় পেয়ে যাবে না, you just see, read, draw few diagrams or one diagram and just label them. You will be given some marks. Blank রেখে আসবে না, খালি ইমাজিন করে নেবে যে সেইভাবে সাজিয়ে ফেলবে। মানে দেখো, the embryological pharyngeal, sixth pharyngeal arch, fourth pharyngeal arch. So these arches are supplied by these dermatomes and somatomes, whatever it is. It is supplied by the nerves. It has to be supplied. Otherwise they won't function. They are destined to perform some activity. Then that activity is lost, or there is some injury during operations. And nowadays many trauma surgery, whatever is the trauma center, then your head neck dissection, also your cardiac operation, mainly thyroid, the ENT surgeons are doing now. Previously general surgeons used to do. So it is important. Now both the recurrent laryngeal nerve supply all the interstitial muscles near the lower pole of the thyroid. Now relation with the inferior thyroid artery, near the lower pole of the thyroid gland, the recurrent laryngeal nerve lies along with the inferior thyroid artery. Hence, for thyroidectomy, the inferior thyroid artery should be ligated away from the thyroid gland to avoid injury to the recurrent laryngeal nerve. Critical integration, injury to the one recurrent laryngeal nerve results in hoarseness of voice and dysphonia. Bilateral injuries may result in both these defects. Now, এটা ধরো ওটিতে যাওয়ার আগে সে বললো কেমন আছো, তুমি গুড মর্নিং বললে, ভালো আছি ডাক্তারবাবু। তারপরে ভালো করে অপারেশন করলে, ওটি করলে, এবার তারপরে সে আর কথা বলতে পারছে না। কথা বললেও তো এখন ন্যাচারালি কে ইএনটি সার্জন হবে, কে হেড নেক সার্জন হবে, no one knows what is your destiny, your fate, your কপাল. So don't think of all this. But question related to your exam, এই ভেগাস নার্ভটাকে একটু বেশি স্ট্রেস দেবে। এটা এই ফিগারটা দেখিয়েছি আগে, ঠিক আছে? রেকারেন্ট ল্যারিঞ্জিয়াল নার্ভ রাইট লেফটের একটু ইয়েটা অ্যানাটমিটা আলাদা, কোর্সটা আলাদা। তো what are the important structures related to the nerve in the head, in the neck, and naturally that is a big component. And also you are now you see if the recurrent laryngeal nerve, হ্যাঁ তোমার যদি রাইট সাইডের ইনজুরি হয়ে যায় তাহলে ইউভুলেটা যেটা আছে ইউভুলেটা যেটা just in the oropharynx, that uvula the paralyzed and it right side is injured, then the shift is there in the left side. So whenever in the post-operative this thing, the patient is under anesthesia, but next when you go in your evening rounds, you try to you just with a tongue depressor, you see the condition of the uvula. ঠিক আছে? Thank you.
Today we will learn about cerebellum. Cerebellum এর লেকচার হয়ে গেছে তোদের? হ্যাঁ কি না? হয়নি? Also known as little brain. It is a Latin word which means little brain. It is the dorsal and largest part of the hindbrain or rhombencephalon. Weight of the cerebellum is about 150 gram. Now, what are the locations and relations? Cerebellum lies in the posterior cranial fossa below the tentorium cerebelli, a fold of dura mater, and it lies behind the pons and medulla oblongata. Fourth ventricle separates the cerebellum from the pons and upper part of the medulla oblongata, and it is separated from the cerebrum by the tentorium cerebelli. Okay. Next, what are the functions? Functions are very frequently asked in your viva. Okay. So cerebellum cannot initiate the motor activity, but it modifies the motor activities and makes the motor activities smooth, fine, and more efficient. It performs three primary functions: maintenance of posture, maintenance of muscle tone, and fine coordination of movements. So these are the functions of the cerebellum. Now the cavity. The fourth ventricle separates the cerebellum from the pons and the upper part of the medulla oblongata. Okay. Now cerebellar peduncles. Peduncles are important because it connects the cerebellum with the brainstem. Cerebellum is connected with the brainstem by three pairs of large white fibers called the cerebellar peduncles. And these are the superior cerebellar peduncle, connects it with the midbrain, middle cerebellar peduncle connects it with pons, and inferior cerebellar peduncle connects it with the medulla oblongata. Okay, so these are the three connections with the three parts of the brainstem: midbrain, pons, and medulla. See here, this is cerebellum. This is a sagittal section through the brainstem and the cerebellum. So this is brainstem lying in front of the cerebellum, and cavity is the fourth ventricle. Tent-like cavity is the fourth ventricle. Here is from above downward, midbrain, pons, and medulla, and cerebellum lies posteriorly. Okay, and this cut portion is showing the vermis of the cerebellum, and this is hemisphere, one hemisphere of the cerebellum. So location, cerebellum is part of rhombencephalon, 150 gram in weight. Location lies in the posterior cranial fossa, below tentorium cerebelli, behind the pons and medulla, and the fourth ventricle. Okay. Functions are extrapyramidal activities, maintenance of posture, muscle tone, coordination of fine movements. So these are the functions. Okay. Cerebellar lesion is very frequently asked in your long question theory paper. Okay, that's why you have to know the function. If you know the function, you can determine what will be the abnormalities. Okay, if lesion occurs in the cerebellum. Next is cerebellar peduncles. 3 peduncles are there. Superior peduncle connects with midbrain. Middle peduncle connects with mons. Inferior peduncle connects with medulla oblongata. Okay. Next, we will go to external features of the cerebellum. External features are asked in your viscera table if you are given cerebellum. Okay. So, shape. Cerebellum is oval shaped and flattened from above downward. It is transverse diameter is larger than the anteroposterior diameter, and the surface of the cerebellum shows numerous fissures. Okay. What are the identification features? Cerebellum has 3 parts, 2 cerebellar hemispheres and 1 vermis. 2 surfaces are there, superior and inferior surface, 2 notches, anterior and posterior notch, and 3 prominent fissures are present, horizontal fissure, posterolateral fissure, and fissura prima. These are the 3 prominent fissures of the cerebellum. Okay, so all these you have to see. See here, this from here to here, this represents the superior surface of the cerebellum. Below this horizontal fissure, this part is the inferior surface of the cerebellum. This midline portion is the vermis, and the 2 sides are the cerebellar hemispheres. Okay, and this small part near the anterior end is the lingula, and here is the flocculonodular lobe. Mean the mid part is the nodule portion of the vermis, and on the lateral side there are floccules. These two are together forming the flocculonodular lobe. Okay, and this fissure you can see, this is fissura prima. Okay, fissura prima separates the anterior lobe in front from the posterior or middle lobe behind. Okay, so 3 lobes are present in the cerebellum. In front of fissura prima is the anterior lobe. Posterior to the fissura prima, this is posterior or middle lobe, and here is the flocculonodular lobe. And this posterior lobe is separated from the flocculonodular lobe by this prominent fissure. This is known as posterolateral fissure. So 3 important fissure you see: fissura prima, horizontal fissure, and posterolateral fissure. Separating the 3 lobes are the anterior lobe, middle or posterior lobe, and the flocculonodular lobe. Okay, and 2 surfaces, superior surface and inferior surface, divided by this horizontal fissure. Okay, understood? So these are the important presenting parts of the cerebellum. Okay, so parts are 2 cerebellar hemispheres and median vermis. Surfaces are the superior surface is convex, inferior surface there is a vallecula, that is a deep notch separating the 2 hemispheres, and sulcus vallecula separates the vermis from the cerebellar hemispheres. Notches are anterior notch, which is the V-shaped and lodges the pons and medulla. Posteriorly, deep notch is present, lodges the falx cerebellar. Okay, this is one dural fold separating the 2 hemispheres of the cerebellum. Next, fissures are the horizontal fissure, posterolateral fissure, and fissura prima. Now, what is folia? Folia are leaf-like lamella separated by fissure. Multiple small sutures are present in the cerebellum. Okay, dividing the cerebellum into folia. In the cerebellum, we have seen sulci and gyri. In cerebellum, there are fissures separating the folias. Folias are corresponding to gyri, and fissures are corresponding to sulci. Okay. Now, lobes, 3 lobes are present: anterior lobe, posterior lobe, and flocculonodular lobes. These are the 3 lobes of the cerebellum. So, parts of the cerebellum, it consists of 2 cerebellar hemispheres, 2 lateral portions of the cerebellum, and vermis is the narrow median portion that connects the 2 cerebellar hemispheres. Now, what are the surfaces? Superior surface and inferior surface. Superior surface is convex, superior vermis, that is superior part of vermis is continuous with the superior surface of cerebellar hemispheres. Okay, it just represents midline elevated portion, but it is continuous. But in the inferior surface, a deep groove or notch in the median plane is present, that is known as vallecula. Okay, and vallecula or vallecular cerebelli, it means groove in Latin. It is a deep notch on the inferior surface of the cerebellum, and that separates the two cerebellar hemispheres. Okay. Sulcus vallecula, it is a sulcus that separates the inferior vermis from the inferior surface of the cerebellar hemispheres, and it is the lateral limit of the vallecula. Next is the notches, anterior cerebellar notch and posterior cerebellar notch. Anterior cerebellar notch is wide, shallow V-shaped notch on the anterior part of cerebellum, lodges the pons and medulla. And posterior cerebellar notch, deep and narrow, it lodges the falx cerebelli, that is fold of dura mater. Next we go into fissures. There are numerous transversely running furrows of varying depth on the cerebellar surfaces. Okay, multiple numerous sutures. Folia, these are narrow leaf-like lamella separated by the fissures. Okay, these terms are important. Folia, what is folia? These are asked in your viva. And each folium consists of core of white matter covered by the grey matter. Three fissures are prominent and consistent, and these three fissures: horizontal fissure, posterolateral fissure, and fissura prima or primary fissure. So horizontal fissure separates the superior and inferior surface of the cerebellum. Posterolateral fissure lies on the inferior surface of the cerebellum and separates the flocculonodular lobe from the rest of the cerebellum, that is corpus cerebelli. Next is primary fissure or fissura prima. It is V-shaped fissure on the superior surface with its apex directed posteriorly. Now, these are the cerebellum is divided into two parts by the posterolateral fissure. Two parts are the flocculonodular lobe and the corpus cerebelli. Corpus cerebelli includes the anterior and posterior lobes. Okay, and corpus cerebelli is divided into anterior and posterior lobes by the fissura prima. Okay, so these are the sequence. First, you will see the anterior lobe, then the fissura prima, then the posterior lobe, then posterolateral fissure, and then you will see the flocculonodular lobe. This will the sequence if you see from above downwards. Okay. Now, what is the tonsil? Tonsil of the cerebellum. Herniation of this tonsil occurs in case of increased intracranial pressure or sudden relief of CSF pressure via lumbar puncture in therapeutic cases, in therapeutic lumbar puncture, if large volume of CSF is taken out, then there is high chance of herniation of this tonsil of the cerebellum. Okay. So it is what is tonsil? It is a part of cerebellum on its inferior surface, and in raised intracranial pressure, tonsils may protrude into the foramen magnum. Okay, that's why it is important. See here, these parts are the tonsils of the cerebellum. Okay, parts of each hemisphere. This can herniate through the foramen magnum in case of raised intracranial pressure. In this view, you see the different parts of the cerebellar vermis and different parts of the hemisphere. Okay, see, this is the midline portion is the vermis, and on the two side two hemispheres. So where from anterior to posterior, anterior most is the lingula. Okay, then there is central lobule. So parallel corresponding to the central lobule, the part of the hemisphere is known as alar. Okay, then culmen, near the culmen hemispheric portion is known as quadrangular lobule. Okay, After that is the declined portion of the vermis, and corresponding to corresponding to this level, the cerebellar portion, hemispheric portion is known as simplex lobule. Okay. And next is the folium. Near it lies the superior semilunar lobule. It lies above the horizontal fissure. Here is the fissura prima separating this quadrangular lobule from the simplex lobule. Okay. Next, here is the horizontal fissure separating superior semilunar lobule from the inferior semilunar lobule. So, in corresponding to inferior semilunar lobule, the vermis portion is the tubal. After that is the pyramid. Near the pyramid, there is biventral lobule. Then there is uvula. Uvula, near the uvula will be the tonsil of the cerebellum. Okay. And posterior most is the nodule. And near the nodule, the portion of the hemisphere is the flocculus. Okay. So this nodule and flocculus are together forming the flocculonodular lobe. In front of this fissura prima, this part, lingular, central lobule, culmen, ala and quadrangular lobule, all these are together forming the anterior lobe, and rest of the portion is forming the middle or posterior lobe. Okay, understood? So you practice this diagram. These parts are asked in your viva or in theory. See here, this is one viscera of cerebellum seen from above. Okay. So this midline portion is the vermis. Here, it vermis only shows like a midline elevation only. Okay. But it is continuous on the superior surface with the two cerebellar hemispheres. See the fissures, important fissures, fissura prima. So in front of it, this part is anterior lobe. Here is the horizontal fissure. Okay. So this is separating the superior surface from the inferior surface of the cerebellum. See the notches. Here is the V-shaped notch, anterior notch. Here is the posterior cerebellar notch, which is containing the fat cerebelli. Okay. Posterior notch is lodging the fat cerebelli, which is extension of the dura mater. And anterior notch here lies the pons, midbrain pons and medulla. This is view from the inferior aspect. Here you can see the inferior surface of the cerebellum. See this midline prominent part is the vermis, and it is separated, and this deep groove is known as the vallecula. Okay, and sulcus vallecula is this sulcus just near the vermis, separating the cerebellum from the vermis. Okay, sulcus vallecula. And here you can see the nodule and floccules. Floccules will look like this. Okay, so these two are together forming the flocculonodular lobe. And here also you can see the sections of different peduncles, superior, middle, and inferior cerebellar peduncle, connecting the cerebellum with the midbrain pons and medulla. Okay. And here this projecting part here is known as the cerebellar tonsil. And so here will be the fourth ventricular cavity connecting the two superior cerebellar peduncle. This is superior medullary velum. Okay, and here is the inferior medullary velum. These two are together forming the roof of the fourth ventricle. Okay, so near the roof lies the cerebellum, and near the floor lies the pons and medulla in the floor of the fourth ventricle. So there are several fissures that divide the cerebellum into number of subdivisions, and the practical differentiation of these subdivisions on gross specimen is sometimes difficult. Okay, hence it is suggested to identify at least anterior, posterior, and flocculonodular lobes. You have to identify these three lobes and cerebellar hemispheres and the vermis. And bald simplex lobule is also called posterior quadrangular lobule. Okay, simplex lobule you have seen in the anterior lobe, that is also sometimes known as posterior quadrangular lobule. So these are the divisions. This chart you remember, from the diagram you can visualize. So for anterior lobe, three parts of the worm is lingula. There is no corresponding part in the hemisphere. Then central lobule, near the central lobule, ala, near the culmen is the quadrangular lobule. And here in the posterior lobe, varnish part is the diclite, near it simplex lobule, okay, or posterior quadrangular lobule. Folium correspond to superior semilunar lobule, tuber correspond to inferior semilunar lobule, pyramid correspond to biventral lobule, uvula correspond to tonsils, okay, and in the flocculonodular lobe there is nodule and flocculus, okay. So the parts of the varves you can remember from this mnemonic: lazy cat died for taka pizza unnecessarily, okay. L is lingula, C is cat is C দুটো আছে, central lobule and culmen. Then D is decline, for F is folium, then T is tuber, P is pyramid, U uvula, N is the nodule. Or you can prepare mnemonic on your own for remembering this, okay. So these parts are important. Next, lobes of cerebellum is divided into three lobes by two fissures. Anterior lobe, it lies on the superior surface, anterior to fissura prima. Posterior or middle lobe lies partly on the superior surface, partly on the inferior surface. It lies behind the fissura prima on the superior surface and extends from posterolateral fissure to horizontal fissure on the inferior surface of the cerebellum. Okay. And flocculonodular lobe, it is a small lobe that lies on the inferior side of the cerebellum, anterior to the posterolateral fissure. Okay, so these are the three lobes of the cerebellum, and this is anatomical subdivision. Next is phylogenetic subdivisions of cerebellum. Okay, these divisions comes in your long questions. What are the different lobes? This anatomical subdivision, phylogenetic subdivision, cerebellum chapter is important for theory. Okay, and the microscopic structure. You have seen the cerebellum in histology. You have not seen cerebellum. Okay, so it is very important histological slide. You practice its diagram. Three layers: molecular layer, Purkinje cell layer, granular layer. You have not seen the slide. Okay. So based on the function and phylogenetic aspect, that is evolutionary aspect, the cerebellum is divided into three parts: archicerebellum or vestibulocerebellum. It is the oldest part of the cerebellum. See here what color coding has been given. Pink color is representing the archicerebellum. It includes the lingula of the anterior lobe and whole of the flocculonodular lobe included within archicerebellum. Then paleocerebellum, blue color code is called paleocerebellum. It includes the central lobule, culmen, and this ala quadrangular lobule. Okay, and here is pyramid and uvular portion of the vermis. All these are included in paleocerebellum. Then there is neocerebellum. Rest of the part, the yellow colored one, is representing the neocerebellum. Okay. So according to phylogenetic division, three parts are present: archicerebellum, paleocerebellum, and neocerebellum. If viscera is given, these divisions can be asked in your viva also. Okay. So based on function and phylogenetic evolutionary aspect, cerebellum is divided into three parts: archicerebellum or vestibulocerebellum. It is the oldest part of cerebellum and it consists of flocculonodular lobe and lingula. Functions are maintenance of body equilibrium, tone and posture of the trunk muscles. Next is paleocerebellum or spinocerebellum. It develops after archicerebellum and consists of anterior lobe except the lingula. Here, whole of the anterior lobe except lingula and uvula and pyramid of the vermis. What are the functions of palliacerebellum? It receives impulses through the spinocerebellum tract and maintains the tone, posture and crude movement of the limbs. Okay, so this is the function of palliacerebellum or spinocerebellum. Next is neocerebellum or cerebral cerebellum. Phylogenetically, it develops last and it is the most recent one, and it consists of the posterior lobe, expect the pyramid and insula, and functions. It coordinates the smooth performance of ski voluntary movements. Okay, so these are the three functions of the three parts of the cerebellum, three phylogenetic divisions of the cerebellum. Three phylogenetic divisions of the cerebellum. Next, we go to the internal structures of the cerebellum. This is important for your histology. It very frequently comes in your theory paper. Okay, histology of cerebellum. Also important for your OSPI if it is given as special slide. Okay, so say it practice a histological picture of cerebellum. Cerebellum is highly folded to accommodate millions of neurons in a small area, and these foldings are called the arborvitae. Cerebellum is having outer grey matter, that is cerebellar cortex, inner white matter, that is cerebellar medulla, and there are cerebellar nuclei. Cerebellar nuclei are grey matter embedded deep in the medulla. Cerebellar cortex is uniform throughout, and cerebellar cortex shows three layers: outer molecular layer, middle Purkinje cell layer, and inner granular layer. These are the three histological layers of the cerebellum, cerebellar cortex. And the cerebellar medulla will be formed by the action fibers afferent and efferent to the cerebellum. Next, we will discuss in details these three layers. Molecular layer. Molecular layer lies just deep to the perimeter.